difficulties of a good pathological diagnosis due to the high heterogeneous group of tumors that we are going to deal with. So, Keith, thank you very much.
Thank you very much, Lisa, and thank you very much to the organisers for asking me, a mere pathologist, to come and speak at ESMO. It's my great privilege to do so. And you will see from the title of my presentation that, in fact, we have a rather large amount of ground to cover this afternoon. So it is going to be in rather broad brushstrokes, and hopefully with enough to set the scene for our other two speakers in terms of looking at some more detail of the oncological treatments and the new oncological treatments which are going to appear for both salivary gland cancers and sinonasal cancers. So I have no conflicts of interest to declare. So we're going to start. I hope that as we go through this session that your journey will be from left to right. Now, I guess the problem with salivary gland tumours in particular is that the tendency is to make it rather complicated, and we find that during the talk that people rather move from right to left. But I'm sure you can tell me which direction that we move in when we come to the questions at the end of the session. So in part one, we're going to very briefly discuss malignant salivary gland tumours. And of course, I'm sure you're very well aware that there are three pairs of major salivary glands, both the parotid, the submandibular gland, and the sublingual gland. And particularly, salivary gland neoplasia is dominated by the parotid. But when you have a look at malignant salivary gland tumours, you will see that, in fact, a little under half, and this is from a very recent scope of internationally diagnosed salivary gland tumours, which was published in Head and Neck Pathology this year, led by the department in Sheffield that I've just left, showed that the parotid was under 50%, and in fact, interestingly enough, about 50% of the salivary gland malignant tumours were in the minor glands. And I think that's a very interesting thing to remember, and they are a very diverse group of lesions. And when it comes to the minor gland distribution, you will see that they are present throughout the oral cavity, and particularly there are some tumours which have a predilection for some areas in the mouth, particularly the palate. I'm sure you'll be aware of polymorphous adenocarcinoma, which almost solely appears in the palate. But there actually can be a scattering of these tumours throughout all of the areas in the oral cavity. Again, I'm sure you're very well aware that we are on the tip of a new classification of cancers of the head and neck, and that includes salivary gland tumours. So this is the 2022 classification of salivary gland tumours. Those of you who have been ahead of the game will, I'm sure, know that this is available online as a beta version, and we're anticipating the print versions at some point over the next couple of months. We have 36 entities, 15 of them which are benign, and you will see on the right hand of the screen that there are 21 entities which are malignant. And this is of the same sort of order of magnitude of the size of classification as it's been for the most recent classifications. There are some new entities which are present within this classification, which is going to be seen later on this year. For example, the microsecretory carcinoma and sclerosing microcystic adenocarcinoma. And then, perhaps a little worryingly for you, given the fact that we already have 21 entities in the classification, you will see that we have another classification of emerging entities, which is the harbinger, I guess, of the fact that in the classifications to follow, it may extend even beyond 21 different entities. And there are some of the emerging entities include intestinal type adenocarcinoma and oncocytic adenocarcinoma, which are well understood but have not made it into the classification at this point. And I think once we will see as we go through the session and the amount of work which is being done in sequencing these tumours, that we have a very open question about whether this is going to expand or how this classification will expand and how useful that expansion might be if it occurs. So one of the questions that I get asked, given the fact that we have this large list of malignant salivary gland tumours, is it really necessary to pursue, as we pathologists sometimes do to a very large extent, getting eventually to a name for the tumour? Is it not just the fact that some idea of risk stratification, which may go along with staging, is all that is required? And you will see this is a low and high risk stratification which comes from one of Raja Sithala's papers from a number of years ago with many of the tumours which have been categorised. And he would, I think, at that time, and I would certainly at this time, say that this is, I think, perhaps a little naive in terms of the classification, and is also a bit simplistic for a number of different reasons. Of course, perhaps the foremost of these is that none of these salivary gland tumours actually read the classification. But we have some tumours which do tend to follow a fairly classic course, yet there are others which do not. We have, in addition to high and low risk, we know that that may or may not transfer over into low grade and high grade. We're going to come back to grading in a little while. That we also, for some tumours, have an intermediate grade. And where do they fit? Where do intermediate grade mucoepidermoid carcinomas fit into this? Where do intermediate grade adenocarcinoma NOSs fit into this? Some people think that they should largely fit into high risk. It also depends on the question that you're asking. What do we mean in terms of high risk? Now, we know that, for example, in terms of risk of local recurrence, that essentially all adenoid cystic carcinomas are high risk. Yet, if you're looking at risk of development of lymph node metastases, it is then really only the solid variants in which that is a significant risk. So it depends, again, very much on the question that you're asking. Again, the names have changed in the classification, and there's one point which is worthwhile making from this list, and it was not called this in 2009 when Raja Sithala wrote the paper, but polymorphous adenocarcinoma was at that time polymorphous low-grade adenocarcinoma, and the low grade from that was removed from the name, given the fact that whilst many of these may be low-grade and low-risk, there are a number of these which are not yet particularly well defined, in which there is a significant risk of lymph node metastasis and are probably acting in a high-grade manner. So given that is the case, I think it is worthwhile that we pursue these through to actually defining the entities. There's always a question when you see the variability, and I'm going to talk a little bit more about the variability as Lisa has indicated, that we have to find out where the boundaries are between variation within a particular entity and when that stops and it becomes something else. And these boundaries are in many occasions not very well defined. But I think it is nonetheless, this is too simplistic and we should get to a definitive diagnosis if possible. So what about the challenges in salivary gland diagnosis? What is it that is a problem for me in my diagnostic practice that then may be relevant to you? And there are a number of these that we're just going to step through in turn. Now, as far as fine needle aspirate cytology is concerned, this is my slide. And yes, this is a little bit tongue-in-cheek, but it does to a certain extent make me a bit of a heretic. Or perhaps I've really just got to put my hand up and say I'm not a very good cytopathologist. But nonetheless, I think there are significant limitations in salivary gland diagnosis associated with fine needle aspirate cytology. I can pretty robustly tell you whether something is a Warthin tumour, but that's not an awful lot of use to you. Can we define various entities in the malignant categorization? That is very, very difficult to do on a fine needle aspirate cytology. But of course, there's been some very interesting work which was shown at the European Congress in Pathology last weekend, showing what we can do in terms of molecular analysis on the cell blocks from fine needle aspirates. So it may not be the end of the road for fine needle aspirate cytology, but as far as my diagnostic practice is concerned, I would far rather have a core biopsy. Now, of course, that opens us up into the next two challenges which are on my list, because you come up against the idea of the small biopsy in a larger tumour. And so we have the issue of variations in salivary gland. There are items, histological, morphological items, which are common across a number of different cancers. And then you also have the problem which is allied to that, in which you have morphological variability within a single tumour. And this is a very useful way of looking at this. It's not completely foolproof, but it's in a paper by Nicole Ciprani from earlier on this year, which categorizes the morphological patterns into 4 main groups. But you will see that there are a number of different tumours named under each of the categories. And so it is not a discrete classification, and there are a number of overlaps. In particular, there are overlaps and problems in diagnosis on occasion, in particularly telling apart the basaloid tubular cribriform tumours and some of the solid nested tumours. But nonetheless, I think this is a very useful way of starting to understand the morphological variability. Now, I somewhat have an analogy, a musical analogy, in relation to this. I think I wonder that sometimes salivary gland diagnosis and the morphological patterns that you have is a bit like sonata form, in that you have a basic morphological pattern, and that is, if you like, the exposition. And then you go to the next slide, and you may well then have a development. And of course, it might not just be one development, and that development might be morphologically very similar to the original pattern that you saw, or it might actually only be evident when you do immunohistochemistry to see that the same cell populations are there. And then, of course, you come to the next slide, then you may well have some extent of a recapitulation of your original features of morphology which were present in the original slide. So that then raises the problem, of course, that when you come to having a core biopsy, or even a number of core biopsies, that you're getting a very small sample of that, and that raises the possibility of what have you got? Is it actually representative of the tumour? And so that places a limitation on what we can do even from core biopsies. But there is, of course, and as a pathologist I'm speaking, I do like to have a place for everything. A place for everything, and everything in its place. And we pigeonhole. And you will have noticed, I'm sure, that in the top left, that there are 2 pigeons in there. And of course, there shouldn't be 2 pigeons in there. And it reminds us, of course, that in terms of diagnostics, that when we insist on having a place for everything and everything in its place, that we will find that at times things don't fit. And there is that compulsion to try and make things fit. And there's a really nice example which has become resolved, I suppose, over the last decade or so, and that is, certainly when I was coming through training, we knew that they were a group of actinic cell carcinomas which were relatively granule poor, but we couldn't think of anywhere else to put them other than pushing them into the actinic cell carcinoma category. But now we have had the expansion in molecular diagnostics. We know that, in fact, those granular cell actinics, which never really quite fitted anyway, with the benefit of hindsight, are actually secretory carcinomas. And we know that they have ETV6 translocations, and they have a particular immunophenotype, which actually does distinguish them from actinics. And so the pigeonholing makes us push some tumours into the classification, when in fact maybe it's time to stop and think, with these tumours that don't fit very well, maybe they are the ones which we should be focusing upon in terms of our sequencing, so that we can actually define them much better and see if they are just variations on a theme or whether they are separate entities. Grading is something which is a particular issue, and that's a question I often get asked when we're sitting in the MDT, come to a diagnosis. What grade is it? My response to that is very often, well, in fact, there is only one salivary gland tumour which has a properly defined grading scheme, and that is mucoepidermoid carcinoma. And even that has variations on it, which give you a different answer depending which one you use. So again, not necessarily particularly helpful. So mucoepidermoid, we use that, we report the grading scheme. Adenoid cystic carcinomas, we know that the solid ones do tend to behave differently, and we tend to report that separately. And dedifferentiation in tumours is high grade. But for the vast majority, we're essentially talking about 19 out of 21. We don't actually have a grading scheme that is worthwhile to use. And so this is a point that we do come to molecular analysis, and this is my point of contact, I guess in this case with Carla's presentation that's coming up. And we know that in terms of diagnostics, there are a number of different features that we use, and we use many of these regularly now, particularly in the tumours that don't seem to fit very well morphologically or immunohistochemically. And pleomorphic adenoma has common PLAG1 alterations, also seen very commonly in salivary duct carcinoma, but that's perhaps something for discussion. The well-trodden path of mucoepidermal carcinoma in mammal 2, and those more recently described ones, including the very recently described PDRK1 fusions in polymorphous adenocarcinoma. And we can use them at times to aid us in diagnosis. But then there are those features which are therefore targeted therapies, and I think we have to bear in mind that when we're looking at a lot of these, we are trying to do the molecular analysis with that in view, and I'll leave Carla to expand upon that in her talk. So when we come to the summary for salivary gland cancers, these, I guess, are the three main issues. There is simplification versus complication. And are things going to get more complicated in the molecular age as we sequence more of these tumours? Well, the answer is probably. The issue of specialist versus generalist diagnostics. This is something Lisa and I have discussed over a number of years in relation to problems recruiting into clinical trials of these tumours and the frequent overturn of diagnoses when patients are at the point of being recruited into clinical trials. And it's something, again, which might be worthwhile discussing. And then this whole tension between morphology and molecular diagnostics. I'm very much of a believer that we need both. As the molecular diagnostics and the molecular features of these tumours are more understood, they need to be related back into the morphology so that we can understand both. So the second part of my talk relates to the malignant sinonasal tumours. This is dominated by two main diagnoses, as you will see here, which are squamous cell carcinomas in the lower half of the sinonasal apparatus, particularly in the maxillary sinus and the nasal cavity, and intestinal type adenocarcinomas in the superior part of that area, areas of the ethmoid and so on. And again, this is the 2022 classification of sinonasal tumours. It's not quite complete. I've taken some out because we would end up running this over 2 slides if I was to put the whole classification up. But again, you will have noticed that there are some new entities. The Sweet-Sniff complex deficient cancers were mentioned in the PLAST classification, but that is an area of increasing complexity with not only SMARCB1 mutated lost tumours, also SMARCA4. And then we have the defining of the HPV-associated multiphenotypic sinonasal carcinoma, previously talked about as the adenoid cystic-like carcinoma of the sinonasal tract, which is now much better defined. And there are other salivary type adenocarcinomas and so on that are not present on here. But this is, as I said, dominated by squamous cell carcinoma and intestinal type adenocarcinoma, which make up about 65% of all of the sinonasal malignancies. And thereafter, you have a list of very rare tumours. And it's really quite difficult to get a lot of diagnostic experience in these, particularly in sinonasal undifferentiated carcinoma, which is a particularly problematic diagnosis. Again, there are emerging entities in the classification. So it is likely that as time goes on, the classification will become more complex. And as you will see here, many of these are molecularly defined entities within the classification. Some are still morphological, primarily, oncocytic adenocarcinoma. But we are now noticing that there are IDH1 mutated malignancies, which are particularly high grade. And these analyses are shining the light into the SNUC, the sinonasal undifferentiated carcinoma category, which has in the past been the head and neck cancer's equivalent of MFH. It's been the bucket into which, when we actually can't call it anything else, we'll call it SNUC. But now we're beginning to understand a little more about the background. And so IDH1 mutated tumours are particularly high grade. There are low-grade tumours which have DECA2 fusions, and then some others as well. But the IDH1 mutated malignancies are a very interesting group of tumours which link the metabolism of the tumour cells with a number of different pro-tumorigenic pathways via these alpha-ketoglutarate-dependent dioxygenases. But once again, returning to the challenges. What are the challenges that we particularly find in sinonasal malignancy diagnosis? The first of these, I have indicated, is that they are rare. Once you get beyond sinonasal squamous cell carcinoma and ITACs, you are into very rare tumours indeed. And the anatomical restrictions of the site in which the biopsies are taken at times makes biopsying very difficult. And on the right here, you will see sometimes the biopsies that we get really very crushed, very difficult to make anything from morphology at all. And when they're that crushed, it is also very difficult to make anything in terms of immunohistochemistry and molecular analysis. There are a number of these tumours which are very high grade and undifferentiated, and that brings the problem of diagnosis of exclusion. And many of them also do need access to very sophisticated molecular diagnostics which are not available in every centre. So here are the main range of patterns that we see, including the keratinizing and non-keratinizing squamous cell carcinomas and the ITACs and non-ITACs, the adenocarcinomas. And in the centre here, you will see the undifferentiated malignancy. This is a case of a SNUC. Now, what's very interesting is that you're putting into this in the classification, which doesn't really appear here, other than the HPV-associated multiphenotypic sinonasal carcinoma, is what part HPV is going to play in all of this. Up to 40% of sinonasal squamous cell carcinomas have been reported to have HPV, and we're beginning to get reports of, for example, HPV associated with sinonasal neuroendocrine carcinoma, which appeared in head and neck pathology in the past week. So that is still a story which is going to run and may well complicate matters in terms of diagnosis and also treatment. But in many cases, particularly with SNUCs, this is where I get to. And it is a case of an undifferentiated malignancy, and we throw everything at it. And you come, and the text will come with a pile of immunohistochemistry, and you've got to go through it. And eventually, when you find out that putting everything together, that in fact it doesn't fit any other entity, then you can call it a sinonasal undifferentiated carcinoma. And so these are challenging in terms of their diagnosis by exclusion. Again, the molecular analysis and utility, and I'm not going to tread too much on Paolo's talk, but we know that there are some features which are very useful for diagnosis. Again, the IDH1 mutation, or indeed even in some cases proving that a tumour is IDH wild type, can be very useful. The undifferentiated carcinomas, the SMARCB1 and SMARCA4 and the SWE/SNF complex, again, bringing the SNUC category into the molecular age and beginning to define it into different categories of specific entities. And it may be that in a generation or so that we do not any longer actually have a category of sinonasal undifferentiated carcinoma. And nut carcinoma, we know that there are variant fusions. Some of the fusions now have been shown to be very aggressive, whereas other of the fusions in nut carcinoma have been shown to be much less so. Molecular therapies, there are a number of these again which are on the screen, and Paolo is going to talk about these in more detail in terms of how we might utilize these features in diagnostics and also taking them forward into therapy. So in summary, again, for sinonasal cancers, the classification is continually evolving. As we sequence more of these very rare tumours, I think it will evolve further, and we will have a number of additional molecularly defined entities to add to this classification in years to come. And the classifications are going to revise more frequently. We're now on a 5-year rolling cycle with these, so that they are going to be updated more regularly. And that comes with an increasing proportion of molecular diagnoses. And I think, yes, we probably will have to sequence all the undifferentiated tumours at some point, unless we can come up with particular molecular diagnostics on the back of sequencing of cohorts of these tumours. So in conclusion, before I pass on to the other speakers, I think in both salivary gland and sinonasal cancers, we are facing an increasing complexity in the classification, which is difficult. It's difficult for diagnosis. It's difficult then to define entities so that they can be effectively treated. And it seems as if we are chasing a moving target at all times. But hopefully this will have set some amount of background which will allow for us to have a look in more detail at the molecular oncology aspects of the development in salivary gland cancer treatment and sinonasal gland treatment as well. So here are my acknowledgements to those in Liverpool and Sheffield. They've been very helpful, and thank you very much for your attention.
Thank you, Keith. We will have time to discuss, and I all invite you to send, in preparation of the discussion, which I think there will be a lot of discussion,